Welcome to Maryland Health Today. Colorectal cancer is the third most common type of cancer in the United States, and it's the second leading cause of cancer-related deaths. However, the death rate from colorectal cancer has been going down in recent years. On the show today, we'll learn the latest about treating colon cancer. My guest is Dr. Nader Hanna. He's the head of surgical oncology at the University of Maryland Medical Center, and he is part of the multidisciplinary treatment team at the Marlene and Stuart Greenebaum Cancer Center. Dr. Hanna is also an associate professor of surgery at the University of Maryland School of Medicine. Welcome to the show.
Thanks, Ellen, for having me. It's a pleasure and honor to be here today.
Now, since we're talking about colorectal cancer, first, could you tell us about the colon a little bit? Is that also known as the large intestine? That's
correct, Ellen. The colon, or the large intestine, is it's part of the digestive tract, and it starts from the appendix. It includes parts of the cecum, as you see on the screen in front of you. It starts with the ascending colon, transverse colon, then the descending colon, sigmoid colon, and the last part is the rectum. The function of the colon in general is to absorb the water as well as some of the nutrients on the diet, and also store the stool until you're ready to have the bowel movements. Colorectal cancer is a very important health topic to talk about.
Why is that? Why is it important to talk about?
Several reasons. If you look at all the cancers in the GI tract, by far the most common is colorectal cancer. In the United States, approximately in almost 149,000 cases will be diagnosed this year in the United States. Approximately 55,000 patients with the diagnosis of colorectal cancer will die at the same time. That gives us the mortality about 37%. What that means is that if you're going to develop colorectal carcinoma, your chances of dying from colorectal cancer is about 37%.
In what sort of time period?
That's once you get the diagnosis. Now, depending on the stage of the diagnosis, let me tell your audience that we have some good news. If you look at the incidence, as you pointed out, of colorectal carcinoma, in fact, it has been coming down since 1998. Moreover, in the United States, we have one of the lowest mortality from colorectal carcinoma.
That's good, but still, it accounts for about 11% of all cancer deaths.
That's correct. Actually, let's go back even to the numbers. If you look at all the cancers that we develop in the United States, men and women, colorectal carcinoma will account for approximately 10% of all cancer diagnosed. It's the third most common cancer in men after prostate cancer and lung cancer, and it's also the third most common cancer in women after breast and lung cancer.
Do you think a lot of women don't realize that they may be as much at risk as the men are?
The risk of colorectal cancer is slightly higher in men than women, but if you look at the mortality from colorectal carcinoma, it's about 10% for men, and 11% of all cancer death is related to colorectal carcinoma. So it's an important health problem. But the good news is colorectal cancer can be prevented, and I think this is one of the message from the show today, that colorectal cancer can be prevented.
How do people develop colorectal cancer?
Well, colorectal cancer, people develop it because of genetic and environmental factor. Simply, you can have several reasons. One, you can inherit a genetic syndrome where you have a predisposition to develop colorectal carcinoma. By far, that's the highest risk. People might be familiar with terms like familial polyposis.
So if one of your parents may have had it, or other close relatives?
That's not inherited. That would be the familial category. Inherited, right. That means every person in the family will have the gene.
Oh, a gene is involved.
Correct. The person will be inheriting a gene that will be responsible for the cancer. And really, there are three big categories of inherited cancer syndrome where a person is susceptible to colorectal carcinoma. Familial polyposis, hereditary non-familial polyposis, and then in breast cancer gene 1, people also have an increased risk. This is where all your cells, there is a genetic mutation that's present in every cell of your body that predisposes you to cancer, which tends to happen at earlier age than the normal average risk person.
Are there some genetic tests for these to
yes.
see if you're at higher risk?
Absolutely. If you meet certain criteria, clinical criteria, or you have a very strong family history where several family members are developing or developed colorectal carcinoma, certainly you can discuss this with your physician and be evaluated and provided with genetic counseling to determine if you do have the risk for this genetic syndrome. These genetic syndromes account for about 5% of all colorectal cancer. There's another category called familial colorectal cancer where it accounts for approximately 25 to 30% of all cases, where there is no definitive inherited pattern, but the person would have several family members that are affected with colorectal carcinoma, and that's by far increases your own risk for developing colorectal carcinoma.
Is that because of environmental factors, or is that because of maybe some genetic factors?
It's actually a combination. You have some genetic elements that predispose to the cancer, but by the genetic elements not enough to develop the cancer. Add to that some environmental factors, and you sure do increase your risk of colorectal carcinoma.
Would you consider certain health conditions like inflammatory bowel disease as being one of the environmental factors?
There are several environmental factors that predispose or can increase your risk for developing colorectal carcinoma. If you look at certain medical conditions, if you look at two specifically diseases termed inflammatory bowel disease, ulcerative colitis, and Crohn's disease, these two conditions do increase your risk of colorectal carcinoma. For example, for Crohn's disease, there's approximately 7% risk of developing colorectal carcinoma over 20 years. And ulcerative colitis, the risk is approximately 1% per year after a period of 10 years of diagnosis.
What if people have a condition known as diverticulosis?
Well, diverticulosis is a benign condition of the colon. It results from different diet habits that we do. It's a benign condition, but it does not increase your risk of colorectal carcinoma.
Well, that's good to know.
Right.
But you were saying that advancing age, after what age should most people be concerned about colon cancer risk?
Most colon cancer develop after the age 50. It's rare and uncommon to develop colorectal cancer before the age of 40. And if you look at the incidence of colorectal carcinoma, it starts to increase significantly between the ages, starting at age 40, and continues to be significantly increased for each decade of life after that. The commonest age of presentation is usually in the 60s, in the sixth decade of life.
Can we do something to prevent getting colorectal cancer through diet or exercise, physical activity? Through diet, maybe eating a lot of fiber, those sorts of things?
Sure. That's a very good question. I think it's important to answer and clarify for our audience. When we talk about prevention of colorectal carcinoma, we talk about primary prevention and secondary prevention. Primary prevention through behavioral modification and diet. For example, we know that physical activity, not only for colorectal cancer, but for general good health, improve your outcomes. So, being physically fit and active decreases your chance not only for colorectal carcinoma, but also decreases risk of your diabetes, heart condition, obesity, and other cancers. So it's absolutely important to be physically active. If you look at a diet, diets rich in vegetables and fruits, diet high in fibers, diet with less red meat and unsaturated fat will help your chances not to develop colorectal carcinoma. There are certain medication that people can take that will decrease the chance.
Really?
Yes.
Such as?
Well, aspirin for one. Non-steroidal anti-inflammatory drugs. Now, that's not that everybody should go take aspirin. You need to discuss this with your physician,
Sure.
but there are certain category. Calcium supplements. If you're taking calcium on a regular basis, that can prevent
a lot of women
decrease your
take
risk.
them to prevent osteoporosis.
Correct. And also for women, for postmenopausal hormone replacement therapy, that by itself decreases the risk of colorectal carcinoma.
Oh, that's very interesting.
Right.
And then a lot of people are advocating screening starting in your 50s to get a colonoscopy.
Right.
Why is that important?
Well, it's important because screening can be effective in preventing colorectal carcinoma, and it has been proven in scientific studies to be effective. When we talk about screening for colorectal carcinoma, we need to know the individual risk, because the guidelines for screening will be different. People know about the colonoscopy, as you see on your screen, where we actually insert a fiber optic scope into the colon, rectum, and then colon. We actually visualize the whole colon and be able to identify any growth factor, growth lesions that can predispose to colorectal.
Polyps, I guess people
That's
call
correct.
them.
That's called polyps, and we can actually resect and remove these polyps before they turn into cancer.
So when you see a polyp, when a gastroenterologist is doing a colonoscopy and he or she sees a polyp, he can take it out right
That's
then
correct.
and there, right, and
Absolutely.
analyze it in the lab.
Right, you are correct. And not all polyps predispose to cancer, but certain polyps, certain histology, that's why we need to look and examine any polyps that's resected to determine the risk for developing colorectal carcinoma. But you are correct, it is diagnostic and therapeutic intervention. But there are various other types of modes of screening that people ought to know about, which would include, testing your stool for blood, a flexible sigmoidoscopy.
Right, the sigmoidoscopy, that goes only up a certain way, right?
Yeah, it goes up to 60 centimeter, but it's combined with testing the stool for blood is quite effective. And using a combination of testing stool for blood and the flexible sigmoidoscopy, we can actually cut the mortality from colorectal cancer by 2/3 for the lesions that are seen within the reach of the sigmoidoscope.
A lot of people still, though, advocate the colonoscopy so that they can visualize the whole thing. And there's something now called virtual colonoscopy that uses a CT scan, right, rather than actually putting a scope up into the colon. How far along is that virtual colonoscopy?
Yeah, virtual colonoscopy has been existent for several years now, and you are correct. Some people who fear screening because of the colonoscopy can be offered virtual colonoscopy.
And this is what you see, right?
That's exactly what you see. A patient actually, this is a picture of virtual colonoscopy where it's actually done in the CT scanner, and then the software kind of analyze the images and provide this 3D dimension picture of your inside of your colon. And here we see, here's what a polyps looks like, and this is actually can be seen in this virtual colonoscopy.
But if you see a polyp on virtual colonoscopy, you should go back for the regular one so that
That's
they can
correct.
take out that polyp,
You
right?
are correct. So virtual colonoscopy does not eliminate the need that if you find a lesion in virtual colonoscopy, you're still going to have to undergo a full colonoscopy to excise and remove the polyp, because that's your chance to eliminate the risk of colon cancer.
Are there any symptoms of colon cancer? Let's say somebody has not had the colonoscopy,
Right.
but they do have some colon cancer brewing.
Right.
Are there some symptoms that we would notice in the early stages?
Yes, there is. Obviously, some symptoms are kind of vague, like abdominal pain. This can be vague symptoms, and a lot of people have abdominal pain, day in, day out, and don't
Could
pay
be
much
from a lot of
attention from a
different
lot of different
things,
reasons.
sure.
But most patients will at some point develop what we call hematochezia, which they would notice some blood in the stools. And one common mistake that quite a few people will often make is that presume this bleeding is from hemorrhoids.
Oh.
Well, you have to be careful about that. You cannot claim it's hemorrhoids unless you're seen and examined by a physician and had a colonoscopy to rule out that this bleeding that you notice in the stool is not from colorectal carcinoma, regardless of your age. We do see colon cancer below the age of 40. It's not uncommon. And you cannot presume it's hemorrhoids that's causing the bleeding until it's evaluated by your physician. Some other people will develop, they will notice some changes in their bowel habits. They will notice change in the caliber of stools. They will notice that they have alternating constipation and diarrhea. Sometimes a patient will come and say, it just doesn't feel normal. Mm-hmm. When you have such symptoms, talk to your doctor.
Would that be a sudden change in symptoms, or does it come over gradually?
It's usually gradually, and it also depends on where the colon cancer is. For right colon cancer, because the stool tend to be more liquid, so you wouldn't notice much of a change in the bowel habits. But anytime you develop persistent change in your bowel habits, abdominal pain, blood in the stools, you absolutely need to seek medical attention and should not delay it at all.
Well, I want to ask you about staging and also the treatments for colon cancer, but let's first take a break, okay? So we're going to take a break, and when we come back, we will talk about the treatment of colorectal cancer and some new approaches and innovative treatments for other gastrointestinal cancers. So stay with us.